Okay, so we're going to start talking about the classification-based management of those with neck pain. We won't spend as much time here in the cervical spine as we did in the lumbar spine, and that's for a couple of reasons. It's not as prevalent as low back pain, and some of the concepts we've really already talked about, and those transfer over, like the concepts of chronic pain, biopsychosocial model, imaging. There's challenges in the cervical spine, just like we had in the lumbar spine. We've already talked about the treatment-based classification system, which is very similar to that of the cervical spine. And then many of the red flags are the same, like cancer are the same, but we do have some new ones like myelopathy, which we kind of covered before as well, but also cervical arterial dissection, which we cover a little bit here and then in detail in the next lecture. So the epidemiology of neck pain, the lifetime prevalence is 22 to 70%, most common in the fifth decade, most common in women, second only to low back pain. So this is something that you're going to see in the clinic a lot. And then the challenge really is that that 30 to 45% of those cases will become chronic. 14% of cases will be recurrent. So what are the risk factors that we've talked about before for those progressing from acute to chronic? So what are we doing for this in the clinic? You see that strengthening, flexibility exercises, mobilization, manipulation are the most common things in the cervical spine, and this is a very different picture from 10 years prior. This was done in 2008, but which is actually good news because it appears that PTs, we think we should be treating with these modalities: strengthening, flexibility, mobilization, manipulation, and on the whole, that's really where the evidence is. And then what are those factors that are explaining an outcome? So age and symptom duration negatively affect your outcome, and the initial function and whether or not those patients receive mobilization manipulation has a positive effect. And so just think about which of these that we can actually control. So what is the evidence for treatment of mechanical neck pain? So this is a 10,000 foot overview, but the combination of manual therapy and exercise is more effective than no treatment. There's a role for exercises in the treatment of acute and chronic mechanical neck pain, and that with a headache as well. For short-term relief, manual therapy had an improved outcomes over exercise alone, but the combination of those improve the quality of life for those in chronic pain. So for mechanical neck pain, we talked about that there's a role for exercises. Mobilization and manipulations, when used with exercise, are beneficial. There's really inconclusive evidence at the moment for traction, but that's really because the studies that were done are of poor quality, and really can't make a recommendation for massage for neck pain. The evidence just is not there yet. But the relative benefit of each exercise needs to be investigated a little more extensively. So when we talk about our medical diagnosis, right, we have something of a pathology-based or a symptom-based. Nerve root compromise falling in that pathology-based. But we see, similar to low back pain, that the majority of patients present with this neck pain that falls into this black box of mechanical neck pain. So it's unlikely that all of those patients in that blue section there are all the same patient and should be treated with the same intervention. So just like in the low back, we'll try to identify subgroups based on exam findings, and then interventions that are matched to those that can provide the best overall outcome. So some pathoanatomical diagnoses that you'll see in the neck: arthritis, discogenic disorders, myofascial pain syndrome, torticollis whiplash, cervical ridic. So if a patient does have one of these medical diagnoses, does that really help you in finding a treatment direction? And what are really the diagnostic criteria for each of these categories? So how would you diagnose a discogenic disorder? How would that differentiate between cervical radiculopathy? So there are some differences in these patients, and knowing the mechanism of injury, we might find out some about whiplash, and that may help us find a treatment direction initially. But for most of these, there's no clear, defined diagnostic criteria for these. And then the true pathoanatomical cause is not always easily identifiable for these. So we come back to this argument of a medical diagnosis versus a classification. So the medical diagnosis, obviously trying to find that pathoanatomical cause for the patient's condition, and the classification system really being taking that clinical data, putting that patient into a category, and then having some matched treatments. And why really are we doing that? So that we're not just throwing interventions at the patient and kind of seeing what sticks. So we have the 2017 neck pain clinical practice guideline, and that was on your reading list. So the first stage of this is really screening for PT appropriateness. So another way to really look at this is, does this patient belong in my clinic, right? Are there red flags that that we need to refer out or consult with a specialist about? And if not, are there any things that we need to consider yellow flag wise that would cause us to modify our treatment or consult with maybe a behavioral health specialist? And if not, then we need to go on to our classification system. So some red flags that will require referral, right, are spinal fractures, so major trauma, severe limitation in active range of motion. We have the wonderful Canadian C-spine rules, so do make sure that you review that. I know you guys have covered it before. Make sure that you're aware of that algorithm. I'm not going to make you memorize every single step, but you do need to understand the general principles of that. If they pass that first part of the C-spine rules, then they go on to active range of motion. And if they fail that, then they need to have some cervical radiographs. Cervical myelopathy, we'll talk about this one a little bit more in detail, but here are the criteria or signs and symptoms of that. So neoplastic condition and cancer, and we've talked about these before. They're very similar to what, if not exact, of what we've talked about for those with lumbar spine pain. In the cervical spine, there's a couple others that we need to make sure we're thinking about. So an upper cervical ligamentous instability, and think about the populations that would be more likely to have this. So those who have had some sort of trauma, or there's other conditions, systemic conditions that we know that make that much more likely, like rheumatoid arthritis or Down syndrome. So vertebral artery insufficiency or cervical artery insufficiency, those are often used interchangeably, but the CAD is really the most updated term because we have to include the internal carotids there. So we've got our 5 Ds as mentioned here: positive cranial nerve signs, and then a systemic condition and inflammatory or disease, and those criteria are listed there. So talking about cervical myelopathy, Cook did this systematic review in 2011, and while really some more high quality studies are needed and manual therapists need to be up to date on that diagnostic information, it still needs some updating and some more rigorous studies. However, based on the current literature, They formed a test item cluster, and you see the cluster there on the right, and then the diagnostic abilities of that cluster there on the left. Hoffman's reflex, you'll see that's listed here on the test item cluster. This is likely very specific for those neurological compromise. So they found MRI evidence of cord compression in 16 asymptomatic patients with a positive Hoffman's reflex. So it's a very specific test that can help us rule in. However, it's probably not very good at ruling out. So how do we rule out? And we need some imaging likely to rule out. So the sensitivity you can see there of MRI will help us rule out. We also need to be taking into account anything that's coming from our clinical exam and the signs and symptoms they're telling us about. So a cervical case here for you. This is a 65-year-old female with, she complained of neck pain, referred to PT from primary care. She had a history of breast cancer at age 50, so 15 years ago, with a recurrence at 5 years. So she had it excised, had chemoradiation, and has not had any issues for the past 10 years. So probability of cancer as the source of her pain. So she's over 50. That increases your chance of, from 0.66 to 2%. History of cancer, though, increases that 2% to a 30% chance. And this patient was continued with PT. The pain increased following treatment. So how long do you really persist in treating this patient? So we talked before about a failure of conservative management, and that's going to be, it kind of depends a little bit, but probably thinking about 4 weeks or so, and we should be seeing some improvement at 2 weeks. So the patient sought a second opinion with plain film radiographs indicating a metastasis to the cervical spine. We've talked before about these signs of cancer and how that influences your post-test probability. Okay. Another case report of a university graduate. So this patient was a 32-year-old male, had an axial load, blunt force trauma to the head when a tree fell on the car in which he was sitting. So the first day at the ER, he had a CT, and that was he was diagnosed with a C1 fracture and referral to neurologist on Monday. The second day, so I think this was not a Sunday, right? The second day he went back to the ER because he had some significant symptoms. MRI and X-ray, no fracture was seen, was sent home and return in 2 weeks for a follow-up. So at day 14, he followed up with the neurologist who referred him to PT for range of motion and strengthening. And so this is where our graduate picked up. So physical therapy at day 16, range of motion is about 10% of normal, pain at 9 out of 10. Red flags present here are that there's less than 45 degrees of range of motion. The mechanism of injury was a dangerous one. And so according to the Canadian C-spine rules, that this patient needed a CT scan, which is required for the C1 is a ring structure, and so you can't see very well on MRI, or a bit better on MRI, but certainly can't see that on plain film radiograph, and so a CT scan is actually indicated for that. So if something's not right and you're not comfortable, you need to ask them to follow up. So the consultation with the orthopedic spine surgeon during multidisciplinary team conference, a clear C1 fracture was seen on CT scan. Therefore, this patient's inappropriate for PT, and so they referred back to the neurologist. Vertebral fractures. So this often occurs after major trauma, MVA, fall from a height, direct blow on the cervical spine, will often result in severe limitation during active range of motion. But remember, on your Canadian C-spine rules, if they may not even get to testing range of motion. Okay, so on our Canadian C-spine rules, does the patient have any high risk factor that mandates x-rays at that time? So that's either age over 65, a dangerous mechanism, or if they have paresthesias in their extremities, do not pass go get radiographs right away. What is a dangerous mechanism? You see that up there in the right hand corner. So if yes, go directly to getting radiographs. If not, do they have any low risk factors for allowing safe range of motion? So was it one of these lower risk mechanisms of injury? And are they walking at the time? Do they have delayed onset of neck pain versus immediate onset of neck pain? And do they not have any tenderness when you palpate the cervical spine? So essentially, you get a history, then you get some more history, then palpation, and then if you can't say no to that, then yes, then you assess range of motion, and it's 45 degrees of cervical rotation to the left and to the right. If they can't do that, then they need x-rays. If not, no radiographs needed, and you may proceed. For inflammatory disease, we talked about these factors already. So if they have a temperature, high blood pressure, resting heart rate's high, these other signs. Okay, so if they don't have any red flags, then we need to assess yellow flags. We talked about fear avoidant behavior before, but here are some other yellowish flags. So coexisting pains, and that's just trying to get at, like a central sensitization. Anxiety, any maladaptive beliefs, that's continued here on this page. So attitudes and beliefs. So catastrophizing, belief that their pain is uncontrollable, passive attitude towards rehab, or behaviors, maybe they're taking a passive approach, or they've stopped doing activities without really a great reason why. Or perhaps self-medicating in some other way, high intake of alcohol or other substance abuse. Okay, so now getting into our exam. Here's proposed exam findings for our clinical practice guideline. You may not be able to read this, and that's not important really at the moment, but know that the CPG has some exam findings that they expect for you to be able to place patients into those categories. And then the next step on the CPG is to place them in an appropriate stage. Okay, so we can think about time-based strategies to do that, but also consider concepts of mechanisms. So we talked about like nociceptive pain, peripheral neuropathic pain, or central sensitization. And in the clinical practice guideline, there's not as much input for severity irritability like there was in the lumbar CPG, and that probably will come out with the next iteration if I had to bet on that. Okay, and then we just match according to those proposed the exam findings, placing them in a category, and then there's some intervention strategies, and that breaks this down in acute, subacute, and chronic for each of the 4 categories that we have here: neck pain with mobility deficits, neck pain with movement coordination impairments, neck pain with cervicogenic headache, neck pain with radiating arm pain. Okay, the old treatment-based classification system had these categories: mobility, centralization, conditioning, headache, and pain control. And you can see this is the category, and then the exam findings, and then the treatments that were matched to that. And this one makes a lot of sense, and I'm including it here so that you can still speak the same language should someone in the clinic be using this language, and also so that you can really understand the literature based on the literature that examined the treatment-based classification. You still used these categories. Okay, and so why are we really using the treatment-based classification? So that things are not just chaos, right? That we have some organization. So does the organization of or categorization of patients work? So this was Julie Fritz and Gerard Brennan looking at the treatment-based classification system for the neck. So this was to examine and refine the TBC, and then to see if the TBC matching those patients actually worked. Okay, so this was the algorithm that they followed in order to place patients into the correct classification. And this doesn't really apply to our updated clinical practice guideline categories, but I still think that this is helpful for you to know. Okay, so they took a cohort of patients presenting with neck pain, did a standardized baseline exam, and then the PT treated at their discretion. The intervention and outcome data were collected weekly, and then the researchers decided whether or not this was a matched treatment or unmatched treatment based on where they placed them in the exam. So this wasn't the clinician placing them in a category or a classification. This was the researchers doing this on the back end. So there were 274 patients. You can see the demographic and baseline scores there. The treatment visits were on average 5.6, and this is how the classification system broke down. So you see that most of these patients were placed in centralization, followed by the exercise or the conditioning category, and then followed by mobilization, headache, and then finally pain control. The percent agreement between the researchers placing these in categories was 96%. So basically that tells us that based on the exam findings, most of us will be able to agree on a classification group. Okay, so here are the percentage of patients receiving matched treatments. So overall, we see that 41% were receiving matched treatment. This may be because at the time we didn't really agree on what intervention should be matched, or there may be other distractions in the clinic that keep us from doing that. Okay, so here we see the disability on the left and pain on the right. And we see that matched classification to intervention did better than unmatched. You see that as well for pain. Now this is not as outstanding as it was for the lumbar spine. Okay, percentage of those receiving a clinically important change based on their oswestry, I believe this was taken from the match, 72%, to unmatched, 53%. And then visits and NDI change, you see change per visit and the amount of visits and change per visit. Here in the matched groups there on the left and unmatched there on the right. So the conclusions from this were that matched treatment was performed less than 50% of the time. Patients matched to the appropriate treatment, though, did demonstrate greater improvements in pain and disability, and there was greater change in disability per visit, and so they were more likely to report significant change. Okay, placing these patients in categories and matching interventions is not exactly rocket science, but the clinicians at the time were not trained to provide those treatments, that we were just looking at trends in the treatment of those patients. Okay, so I just want to summarize the old TBC. So it follows a similar pattern, right? The initial classification, PT appropriate consultation, and continued treatment or referral out. And then the categories that are important, right? Mobility, centralization, pain control, and conditioning. Those were updated here. These categories: mobility deficits, movement coordination impairments, that includes whiplash associated disorder, headaches, and radiating arm pain, radicular. But the 2017 followed this flow. So medical screening: does this patient belong in the clinic? Are there other yellow flags to consider? Placing them in a diagnosis, which is really your placing them in a treatment-based classification system category that's going to direct your treatment, determine the condition of their stage, and then find the intervention that is matched to the classification and the stage of their condition.